Good morning, everyone. I'm so glad that you're able to make the session this morning. Thank you so much to the DRWF for the invite to speak about a topic that's really close to my heart. It's really important to me personally, but I'm sure we're going to find out more about that as the session goes on. So today, I've been joined by a wonderful panel who are going to introduce themselves shortly. We're going to be talking about tackling diabetes inequity in UK Black populations, and we're going to have some lived experience contributions. What we're going to do today is find out who's in the audience, do a quick review of the inequity in diabetes that we are seeing in UK Black populations. We're going to have a panel discussion and have some time for Q&A. So who's on the panel with me today? I think let's start at the bottom. Dan, would you like to introduce yourself, please?
Hi, morning everyone. My name's Daniel. I've been living with type 1 diabetes for over 28 years, and I'm a diabetes advocate.
Morning everyone, my name's Tilieka. I've been living with diabetes for almost 4 years now, and I'm a diabetes advocate.
Morning everyone, my name's Amelia. I've had type 1 for 26 years now, and I'm a diabetes advocate.
Morning, my name is Hudson. I'm a diabetes specialist nurse based in Birmingham, and I've worked in diabetes now for about 28 years.
And I'm Bernadette Adeyileka-Tracz. I'm actually a pharmacist by profession, but I'm the Executive Director of Diabetes Africa. We're a non-profit organisation, and our whole mission is to reduce diabetes inequalities for people of Black heritage, and we also have projects in Africa and starting in the Caribbean. But obviously my focus at the moment is tackling inequalities in Black populations related to diabetes in the UK. So, quick show of hands. I recognise quite a few of the faces, but I'm wondering who in the audience is a healthcare professional? Person living with diabetes? Researchers or other? Some covering both, which is brilliant. Right, so the reason I'm going to start with this slide is sometimes we get feedback that people don't believe there is inequity in diabetes outcomes for Black populations in the UK. So I wanted to make the case for 3 specific areas where we are seeing inequity, and that's access to diabetes technology, being well prepared for pregnancy, I'll share what that is shortly, and also chronic kidney disease in people living with diabetes. So the first one is Black children and young people in England and Wales have less access to diabetes technology. And as you can see from the graph on the bottom left, that's continuous glucose monitoring, and the next bar chart is insulin pumps. And the white bar is white children and young people, orange bar is Black children and young people, and you can see in both cases, for CGM and pump, that Black children and young people have less access. And the chart on the right-hand side is showing the difference between Black children and white children. And over time, from 2020 to 2023, the gap between those two groups is actually getting wider. We hope this will change, but it's just to illustrate the point. And often we're told, oh, that's because people of Black heritage are often living in more deprived areas, they have a lower socioeconomic status. But what this graph is showing for CGM on the left bars and insulin pumps on the right, that even if you take the most deprived groups and compare them to Black children and young people, which the bars on the orange bars will also include Black children and young people with high socioeconomic status, Black children still have lower uptake and access. So this is a continuous problem that we're seeing, even factoring in socioeconomic status. The next example is being well prepared for pregnancy. So well prepared for pregnancy means that the women are not on statins, they're not on ACE inhibitors, they're not taking any other medication which is contraindicated in pregnancy, that they're taking 5 milligrams of folic acid, and also at 28 weeks that their HbA1c is less than 48 millimole per mole. So basically, good control, ready for giving birth. And that has positive outcomes for mum and baby. So the graph is a little small, but what we can see here is, this is Asian, Black, mixed, not stated other, and non-white. So we're comparing white women, the last bar chart, and the second line is Black women. We see that criteria well prepared for pregnancy, fewer Black women are well prepared for pregnancy, and we know that has poor outcomes for mum and baby moving forward. And the final example I'm going to give is, this is for at risk of renal replacement therapy, so things like dialysis, hemodialysis, peritoneal dialysis. And the orange lines are Black men and white men and women with type 1 diabetes on the left and type 2 diabetes on the right. And the blue and grey lines are Black men and women with type 1 and type 2 diabetes. And you can see in both graphs that the risk of needing renal replacement therapy is significantly higher if you're of Black ethnicity. So there are things that we need to do, and there are examples of inequity that we're seeing. And so I wanted to, with that as the foundation, move into the panel discussion and I guess ask 3 questions of our people with lived experience and also Barbara, diabetes specialist nurse. In your view, what's the biggest cause of the inequities that we're seeing? And it doesn't need to be from these examples, it can be from other areas. How does that link with your personal experiences? And what can be done to improve the situation? I'm going to go in the same order again. Dan, can you kick us off, please?
Do you want to start the first or through?
As you wish.
Can you just repeat?
Okay, we'll do one at a time. We'll do one at a time. So, in your view, what's the biggest cause of the inequities we see? And it doesn't need to be these, it can be others.
So, for me, I think the biggest cause is having access to, well, firstly, access to information and knowing what you're entitled to, and then getting what you're entitled to. So I think for me, I'm very fortunate. So I started working at a type 1 diabetes medical research charity in 2013. And when I was there, that really opened my eyes to what's available, how to actually navigate the healthcare system and have the confidence to challenge healthcare professionals. If I'm told no, it's okay to challenge, and then how I do that. And had I not been there, I wouldn't have known that. And I would have just been reliant upon my healthcare professional telling me what I can and what I can't have, and not have the confidence to challenge or to find out what I'm entitled to. And I think that's one of the dynamics that takes place in the consultation, and I think within our community, is that, for me anyway, growing up, was always thought you must respect the healthcare professional or the doctor and take what the doctor's saying as truth and don't challenge. I think if you still have that belief and you go into those consultations, then you just take what they're saying, but you don't know that you can challenge and then get what you're entitled to. So I think that's one of the reasons for me.
I would definitely second that. I'd say it's the information that you're given, the lack of access to different things. So I was diagnosed during the pandemic, so I've had consultations where that's been used as an excuse as to why I've not been seen that much, or why I've not been given certain information. Oh, it was during COVID, so that's why. Which a lot of the time throughout the last few years, it's just I've been left in a state of limbo. I don't know what's going on, or I'm not too sure why, but I'm not able to challenge it because I don't have access to certain information.
I agree with all of them. It's sometimes not knowing. I'm quite stubborn. So, and if I notice someone else has got something and I'm like, why have I not been told about this? I will question it. But then it's always told, oh, because you're not looking after it, you can't have that. Or if you look after it, you may get it. If you do something for me to help you, instead of going, okay, let's just see how this works. And if it's going to help, then this is what we stick with. But it's all about what you know. When I was first diagnosed, I knew nothing. I didn't even know it existed. So it was like starting fresh. And as I've got older and had it for quite a time, I'm still learning new things. But now I know that I can go and research things before I ask, can I have it?
Barbara, from your clinical experiences, anything you want to add to what's been shared so far?
I think the first thing I would add really is that when sometimes people say you have to treat everybody the same, but I think that myth is not correct in my view. And it's about asking the right questions, building trust, and actually seeing what the person who's living with diabetes wants, see what their agenda is to begin with, and actually to find out what they actually know. And then once you build that relationship of trust, and you can have this dialogue, then you can give them the information they need at the time that they actually need it. And I just find that, you know, my first thing would be is, do you know why you've actually come to your consultation? The second thing would be is, what would you like the outcome to be and what can I help you with? So I literally use that as the foundation to move forward with that individual. And then with that, you can find out what they don't know and what they need to know and how you get there. And it's very much partnership. And I think that's kind of the best, and that's changed. And I will echo what Daniel said. He actually said, you know, you respect that healthcare professional that you come in, because my parents are the same. They literally do as they are told. And when you actually offer somebody the chance to make their own decisions, they'll go, I don't know, you're the healthcare professional, I've come in to see you. And it's about changing that dialogue. And the only way you change that dialogue actually is to inform them or educate them about what needs to be done, and then they can make an informed decision. And it's literally, it can be a very slow process. You have to change people's perceptions or point of view, the way they manage their care, because it has changed in the period of time. It was, you do as I do, I'm sorry to say that, but that's how it was. This is what you've got, this is what you need to do. And I've evolved my practice to go the other way and to find out what do you want and what we can do. And there's a difference, I think.
Thanks, Barbara. And Dan, Barbara, you've mentioned a key point that I think might be worth discussing. Part of my upbringing, my heritage is Nigerian. Respect was a huge part of, I guess, the culture. And you had to respect your elders, your aunties and uncles. For those who are not familiar, even if someone's not your blood relative, you often refer to them as auntie and uncle. So there's really this respect of elders and people in respective positions. And I wonder how that interacts. I mean, Dan's touched upon it, how that interacts in a consultation where you might be hesitant to challenge an authority figure. And I think let's call the elephant in the room. There are biases of angry black woman, angry black man, and trying to avoid any perceptions of fitting into that stereotype. So I don't know if anyone wants to comment on that further. Dan, go ahead.
So I think that when it comes to the respect, it's definitely, well, for me it was there, and then I wouldn't say I lost it. Obviously the respect is there in the consultation, but my mindset shifted to, this is you're there for me. What can I need to get the best out of this appointment, or what do I need to get out of this appointment, rather than thinking, oh, I just need to go, and you're the one who's going to give me all of my solutions. What am I going to get? And then there's flipping that, but it's easier said than done. And then when it comes to the kind of the stereotypes, I think I'm consciously, subconsciously aware of, if I speak a certain way, then it's easy to be labelled as angry. And even when you've been treated unfairly, you can't express it a certain way, because then if you do express it that way, then if that label's then thrown back at you, then you're now given a marker which can then affect you getting any help or support that you might further need, whether we want to admit it or believe it happens or it doesn't happen. It does happen, and it can happen, and that's always in the back of your mind of, okay, I need something, how do I navigate this? But even though something's I've been treated unfairly, and that's hard. And again, when it goes back to people asking for help, if you don't have the confidence to do that, and you just get told that, and you don't want to fight, and maybe you're just tired of fighting because there's a lot of fight that goes on outside of healthcare. Why are you then going to do that? And then say, oh, I don't want it. But you need it, and we all need the technology to help us, because then it's us where our health is affected. So yeah, there's a lot to go on.
Thanks, Dan. Tilieka or Amelia, anything to add to that? Oh.
I agree with what Daniel says. I kind of go in going, okay, am I doing the right thing? And there's been times where I've been told I'm not doing the right thing. And I have to stop myself from saying what I really want to say, and I just sit there and I shut down and I go, well, you've not helped me to find that solution. You've just told me I've done the wrong thing. And that's that. And then I think as well, I'm quite forward with it when I'm sitting there, because I get that you're the healthcare profession, but it's a lot harder to live with if you don't experience it yourself. So as much as they're all going, yeah, you should be doing this, you should be doing that, actually, sometimes when you are doing what you're supposed to do, it's a lot harder. And they don't tend to see the struggle of you struggling with it. All they're looking at is that the data's not where it should be. Which one?
Okay, I think there's another thing is the cultural perceptions of health, and I don't know whether there has been any in-depth or a lot of research into that. Is literally, I guess you have to have an interest in it. But I did speak to somebody the other day, and they were saying that their friends, when we're talking about the use of technology here, and it was, why would you want to wear something that will highlight your condition? And it makes you look sick, yeah? And what is diabetes anyway? So that does go down to diabetes as well, and different cultural beliefs around health. And Dan, you were saying something, weren't you, about how people perceive you with having diabetes. Do you want to sort of elaborate on that within the culture? Yeah.
Was that this morning?
Yeah, that was this morning.
Was that talking? I can't remember. Was that us saying us three?
Yeah.
So that's what I was saying. So when I was giving the example of the three of us sitting here in front of you today, talking about our experiences, we've had to overcome certain cultural beliefs around health. So what we've spoken about, at one point, the three of us were thinking that way, but we've had to overcome those challenges of breaking free of what is kind of shared as almost like cultural norms when it comes to health, to actually realise, no, we're not going to follow that path, we're going down a different path, and we're going to make sure that we're doing the best that we can for our health. But going against the flow of your culture, particularly in Black communities, is hard. But we've had to overcome that to be here today, and I think that's another challenge that people living with diabetes or living with chronic illnesses face, is that because the wider culture around you doesn't talk about health, and you're that one person, you have to make that change. It's not as easy as people might think, but for us, as I said, for us to be here today, we've done it, and it's been a challenge, and it will always be a challenge, because we'll always have comments from family members and just wider culture, but that comes into play as well when it comes to getting help and the help and support that you need.
Thank you, Dan. And a point I wanted to touch upon, because you said cultural perceptions of health. My heritage is Nigerian. My parents are very religious, and some of the phrases that I heard grow up my whole childhood as I reject it, it's not my portion, and God will do it. And I think those themes, I think amen. Amen to that. But I think those are quite pervasive and can sometimes come ahead of what we could call conventional medications. So I think Barbara and Danny mentioned a relationship with your healthcare professional to be able to talk these things out, for the reasons why someone might say no to something, to come forward to actually have that discussion. I always feel that there's 3 pillars. It's the relationship of the healthcare professional with the person living with diabetes and their family, how problem-solving, proactive, positive the healthcare professional is, and then also how much time they actually have to spend with the person living with diabetes. Because I think without those 3 pillars, we're going to struggle to make progress, I think. Go ahead, Barbara.
And the other thing the other thing I also noted, and obviously I work within diabetes and have done for many years, is that at some point I didn't realise, and I don't think we have the numbers, and I wish we did, to identify how many people of black heritage actually have type 1 diabetes or different variations or variants of that, and how many have. There's lots of subtypes of type 2 diabetes, and also the realisation that some treatments potentially won't work, especially with type 2 diabetes, and then also looking at the adherence. So a very simple analogy is ACE inhibitors don't work for people in Afro-Caribbean population. So there may be medications out there that we're giving people that don't necessarily work as well. And also the diagnostic criteria may be very different, and the onset of different complications as well, and different phenotypes. And I don't feel that there is enough research out there for us to we need to be looking at that. And that leads me to the other point of do we actually have enough people from those ethnicities that enter into studies so that we can then see the difference and decide on the treatments? Because when I try to enrol people into studies, they're very distrustful. They want to know what people are going to do with their blood, what people are going to do with their data, etc. So I kind of think there's a lot of work to be done, and just simple things like looking at the inequities of using tech. I think tech is amazing, and if I had the money, I would give it to everybody. But you know what? Not everybody wants it. And we probably need to be looking at the reasons why and the barriers behind why people don't want to uptake treatment that potentially can change their lives and their quality of life.
Yeah, and I think when you say people don't want it, you fold that on with a great point. Let's actually find out why. Because some of the reasons might be they don't have a good relationship with their healthcare professionals, so they just don't want to have any more engagement. It could be a multitude of reasons. And I would not like people to leave here today to say they're thinking that maybe black people don't want the technology. I think it's a great advancement and it changes people's lives. So I think we should. All right. So I'm wary of time. Time's going. So if I can go, I'll go the opposite way. If you could say one thing that could be changed, that could tackle inequality or inequity that we see, what would it be?
For me, it's more of the stereotyping and thinking that if you say no, that I'm going to get angry about it. As long as you explain it, I'll be like, okay, I'll try something else.
For me, I'd stick with the access to information, or more so the education behind it, because for myself, I don't feel like I know much more than the day I was diagnosed about this disease that I'm living with, as well as the people around me, as well as that relationship with healthcare professionals that we spoke about. Like, it's only now I'm starting to sort of advocate for myself and speak up for myself and question, well, why is this, or what are the options? A lot of the time, the options are not given. It's just you're given this option, that's it. I've had times where it's like, I've said, this doesn't agree with me, this makes me feel unwell, and my healthcare professional's telling me, oh, that doesn't make sense. Right, but that's my experience. So I think if I had that information to say, well, actually, this is another option, and like Barbara said, there's lots of different subtypes and things like that. I wasn't aware of that. So from the day I was diagnosed, I wasn't given a clear diagnosis. And if I had known that that's a regular thing, or that there's other types out there that are not just flat out type 1, type 2, then that would help me have a peace of mind and a better control of my diabetes. So it's just educating as many people as possible, I would say.
And for me, I think it's kind of been a theme, what we said, is around just building that trust, and seeing the person living with diabetes not just as a, particularly type 1, just a data churning machine, but as a person who is, I don't know, Daniel living with type 1 diabetes, rather than type 1 diabetes is living with Daniel. And I think that's a key thing for me, is the trust, access to information, and then maybe going back to Barbara's point, what outside of that is around research and having more research in the area, and enabling us to have that data that can then hopefully drive and lead to change.
Thank you, Dan. I just want to touch upon one thing before we move on to the questions, because you mentioned, Tilieka, about access to information. So my dad is living with type 2 diabetes, and we were living in Scotland at the time when he was diagnosed. And when he came home with the information leaflet about how he could change his lifestyle to improve his outcomes, it was a slide with like pasta, salads and stuff. My dad is a Nigerian man. He's like, where's my jollof rice? Where's my ewa? Where's my... So it just, the information he received was completely, it didn't resonate with him at all. My mum does most of the cooking, so all the consultation went to my dad, not my mom. It's all these things that we take for granted, that culture of humility, of understanding some of the things that might be common in people of certain backgrounds, that can make all the difference. I know things are getting better. Prof. Goff is speaking afterwards about a culturally tailored program for people of African and African Caribbean heritage, but I think there are many, many ways we can make a difference to people, and I like the points that everyone's chosen. We have some time, so any questions, any comments? No? I'm going to pick on you because I know you're a PhD student, Immaculate. So I'm wondering if you want to say briefly what you're working on, and does it resonate with anything that we've spoken about today?
Yes, sure. Thank you very much. Well, I've actually got some slides from Immaculate, which I'm going to be presenting in the next session in the room next door. So if anyone wants to come and hear that, you're very welcome. But yes, I've got a PhD student called Immaculate. Unfortunately, she couldn't be here today because it's her birthday.
Oh, happy birthday!
But her whole PhD is about improving self-management of type 2 diabetes in patients of Black and African heritage in the UK. And she's been working on a systematic review of qualitative studies. And yes, a lot of what you've said resonates. A lot of the studies talk about the cultural importance of traditional foods and how people see that as part of their identity. And as you said, a lot of the information that the NHS provides just doesn't take that into account. As you also mentioned, there's the gender roles, maybe more so than in other cultures, about men generally don't cook. And so, they, especially men living on their own, are not very good at, adapting how they're preparing food and so on. And then the thing that really surprised me was the issue of stigma and how people don't like talking about diabetes. They don't like telling other people they've got diabetes. And when you combine that with social events where there's lots of food, quite a lot of carbohydrate-rich foods, and people don't feel able to say, well, I'm diabetic, then that becomes a challenge as well. So yes, absolutely, it resonates with everything that you said. Thank you.
Thank you. Thank you so much, and forgive me for putting you on the spot, but I'm going to do it again. Mira, I know you've done I know you've done so much work in this area, especially related to technology. Do you want to say a little bit about it?
Sure. Yeah, thank you. So I'm Mira Ladwell. I'm a doctor in London, and where I work, we look after a lot of Black people with type 1 and type 2 diabetes. And I've also been involved quite a lot in recruiting Black people to diabetes studies. So everything you're saying is my bread and butter, really. It's really part of my life, and I really became much more interested in it. I remember it very vividly when I was looking after a patient on the hemodialysis unit, and I stepped onto the unit, and I had, I think, a whole row that were all my patients that all had diabetes on dialysis, and they were all Black. And I looked at that and I thought, what's going on here? This isn't right. I'm seeing too many lives ruined, by this condition. So we have, where we are, done a great deal of community outreach work. I think one of the things has been that we can't sit in our hospital and expect people to always be coming to us. We need to go out there a little bit more. And our rates of technology uptake in Black people have increased tremendously with that work. And I suppose that what it all boils down to is the word that I think was mentioned quite a few times by everyone, which was trust. Because I think that the default for a lot of people is not to really be quite wary and not have full trust in what I'm telling them to begin with, because I'm not part of that community, and because, for very good historical reasons, the history of what's happened to Black people in medical research is a very, very horrific history. So it has actually taken time to build that trust and for people to understand, because how can we move forward at all if you as a person don't feel that what I'm trying to tell you or offering you is actually truly what's in your best interest? Healthcare completely relies on trust. It completely relies on you saying, okay, I'm going to look at you and I'm going to believe that what you're telling me is honestly the best thing for me, and that you're going to try and do your best to keep me safe and to keep me well. Without that, there's nothing.
Thank you, Mira. Really well said. I realise this is a panel discussion and I'm up and down, but Swati from Kidney Research UK.
Thanks, Bernadette. Hi, everybody. So my name's Swati. I work at Kidney Research UK. Know some of you guys, and everything that you've said today in this panel has resonated, especially around the health inequities within research. And Mira, you've absolutely nailed the point that not a lot of people want to talk about is the historical and cultural context of research and how it was misused. And unless we address that, I think we have a huge issue of moving forwards with bringing that trust and helping to break down some of those barriers. My question was to Barbara around what your thoughts are with that dynamic of the cloak of authority that healthcare professionals have in this dynamic. What do you think the role of patient-reported outcomes are in terms of driving that conversation and allowing the patient to be the one that leads it? There are loads of outcomes and, proms. What are your thoughts on them actually being utilised to give a voice to patients to advocate how that conversation and that treatment session goes?
I guess the first thing that's really important, because it's not about our agenda, and there are many consultations that I've had which haven't touched the treatment options for that particular individual for that first kind of communication, because you've got to set the scene. There are certain tick boxes that you have to get, but does it really mean it has to be at that first intervention? So you can use it as a baseline, but it's really important that you identify what their agenda is at the very
And what they
beginning
want, so.
and what they want. So that, I think, that's how you need to set the scene, because that can actually make a difference to your future relationship, and actually you find that you move forward a lot quicker by doing that. I don't know whether that answered your question.
No, yeah, absolutely. I guess the challenge is, like you said, that it doesn't become tick boxing.
Yeah,
Of like the patient's done the proms, the voice projects that they've done the proms, but it just gets put to one side because I've got to look at your HbA1c and all your bloods and
so
everything
you're aware
else.
of all of that anyway,
Yeah.
and you are discussing the importance. But I think it's as they've all said, it's why are you asking me those questions? You need to actually say, this is why we do X, Y, and Z, and this is why we would like it to be better. What would be your first goal? And you know that perhaps in time we're going to move that down because we're actually doing that for a reason.
Yeah.
And usually they don't know the reason behind it first, or you actually use it, as Dan was saying, they use it as they weaponise that information against you. If you don't get this, you're going to get that.
Yeah.
And let's stop using that, let's turn that around to inform them first.
Before we go to another question or comment from the audience, Dan, Tilieka, Amelia, do you want to comment on that interesting discussion about, how the relationship is framed by the healthcare professional? Tilieka, do you want to go?
Yeah. In my experience, it definitely does. Like, I've had appointments, consultations where I've left feeling absolutely deflated, and I've also had ones where I felt better. I felt like, okay, I've come here, this has helped. Personally, having Barbara as a healthcare professional is amazing. I feel as though she treats me like a person, she speaks to me like a person, she'll ask me my experience, how it relates, she'll tell me what I need to do, what to plan to do, but then she will relate it to my actual life, whereas I've had appointments where it's just like, this is what you need to do, keep taking your medication, do this, and I'm like, but it's not working. Yeah, well, you just need to do that. And that makes a massive difference to how you move forward. My current situation, I feel as though I was basically traumatised, and that's by a healthcare professional. So it's just not having that trust to this day. It's put me off a lot. It's changed my perspective of, okay, I can't trust everyone. I need to know why I'm doing this. I need to know what I'm putting in my body, and as well as what you have mentioned, that cultural element, it makes a big difference, because I was raised in a Caribbean religious household, so you have that respect your elders, respect your professionals, you have that we don't do medication and all of that, so it's hard finding that balance of, well, I don't want to put this stuff in my body, but it's helping me survive. So when you've got somebody there that's explaining to you, well, this is going to help you with this, or this is what this is, I know you might not want to, but it will help, that makes a massive difference. That's been my lived experience. So having someone there that you can trust and that will explain things to you as you, not as a number or data, that makes it more bearable.
We'll go to Dan and then...
It's just a really kind of quick point. So earlier, and I think that perhaps when it comes to the diabetes area of healthcare, there's opportunity to learn, from my experience, opportunity to learn from other areas. So earlier this year, I had a family bereavement. I lost somebody really close to me. I hadn't shared, so I had a kidney transplant in 2018. And when I had my first consultation with my diabetes consultant after the family bereavement, I was told that I wasn't doing well when it came to my levels and my management. And then further on into consultation, my consultant read the letter from my kidney team, and it said Daniel has experienced a family bereavement. And at that point, the whole conversation changed. And there was an understanding of, oh, he's gone through something. And why I say that is in comparison to my kidney team, when I met them and I told them that I'd gone through this family bereavement, their response was, how can we help you? How can we support you? We know that I said that I haven't been taking my medication as I should. That how can we help you? How can we support you? And that example of my kidney team, they had built the trust over a number of months, a number of years, and they've not just seen me as a number, they've seen me as a person. And I think that that's where the diabetes part, some, not all, but some teams can learn from other departments of just seeing you as a person. And sometimes I think when the word diabetes comes into play, people automatically think data, number, HbA1c needs to be there. And an example is just when I've had appointments with ophthalmologists and they've asked me what my HbA1c is and told me, somebody said, oh, that will tell me everything I need to know. And little comments like that, it doesn't at all. So yeah, it's really an opportunity to learn from others.
Thank you, Dan. Thank you, Tilieka. And I think it's important that we had a conversation yesterday about the comment, I don't see colour, and what people's intention is when they say that, you could say is positive. They're trying to say in some cases, I see that you are of a different ethnicity to me and that doesn't matter to me. I still value you, but it can also mean I completely disregard any experience that you have as a result of your ethnicity or looking different. And I think that as a Black person, I'm going to generalize. I'm going to say, as a Black person, in every interaction, especially in the UK, when you're a minority ethnic population in a country, in every interaction, you have to think, is how much of this is because I'm Black? And I think that that's a burden to carry. I'm not living with diabetes, but imagine living with a long-term chronic condition, many people living with many, carrying that into every interaction, into every discussion, into everything is a lot. But I'd like to go to the audience again. I know if you bear me some extra time, because I know we've got the break. Go ahead.
Thank you so much for giving me this opportunity to talk. Sorry I came in late. I want to acknowledge the speakers. They've done very well because everything they've said is actually what is happening in our community. But my worry here is about the emotional well-being of these people living with diabetes, because we have a charity in Wolverhampton called the Global Diabetes Initiative, and we support a lot of people from the ethnic minority, and emotional well-being is a big issue, and the GPs are causing some of these issues because there are so many things they tell them. They go back home, they get so worried about everything that they've been told. If I come and I have diabetes and you are my GP, you say go and eat healthy. What is the definition for an African person who has never been to school to understand what is eating healthy? You've already given them that mental talk to go and stay home and start thinking what to do. So education is the key. Let us look at the emotional well-being because our people are suffering and we have to go out there and educate them. Another point I just want to highlight, I came in here and unfortunately a lot of people within our community, I'm not sure if they know about this or they didn't just want to come. Look at, there are lots of information here today for our community and they are not here, and I want to say that you coordinating this panel, take that to the team so that next time they could invite quite a lot of people that are affected by this, or reach out to other organizations that they are helping people with diabetes so we can arrange and bring some of them here. Thank you.
Let's work together, let's partner. We come to see me at the stand later and we can discuss further, but I think thank you for your contribution, for everyone's contributions. A wonderful session. We could go on, but I know we're getting signals at the back that we need to round up. Thank you so much, Daniel, Tilieka, Amelia, Barbara. Thank you everyone in the audience. Thank you DRWF for the invitation to come and speak about this topic. you can come and see us at the stand and contact us on our socials if you want to continue the conversation. But thank you so much.